discussion, I will stand. So why don't you sit here so we have sufficient space, or is that okay, Marcus? Here is okay? Or rather here? Because afterwards they come. Yeah, I will then leave this space.
Okay.
So I'll show you what I wrote down. When we met yesterday. So we said. So we said one was this entire value of engaging the stakeholders. That was Margaret who said. Engaging all the different stakeholders. Engaging the stakeholders. And the second was the entire process. This is what Cecilia will say. Okay? So it's the she said introducing of these new health interventions needs to have coordinated approaches end to end, and she will present this access delivery part. Yeah. And Cecilia is the last.
Il y en a à la pause café, mais ils vont venir petit à petit.
And it's of course later. Okay, good evening, everybody. Very warm welcome to our scientific symposium, which has a rather lengthy title, From Bench to the Field, Contextual Complexities in Access and Delivery, New Health Interventions in African Health Systems. I'll try to come back to why this title was chosen. My name is Jürg Gutzinger. I'm the director of the Swiss Tropical and Public Health Institute, and I do this session co-chair with my dear colleague, Professor Evelyn Anza. She's from the University of Health and Allied Sciences in Ghana. And the symposium is organized by our dear colleague, Professor Margaret Gyapong. So she's also at the University of Health and Allied Sciences in Ghana. She's organizing the symposium because she has the EDCTP project saving, and I will quickly introduce, but then in greater detail, our first talk. What I would like to start with, you probably have asked, what is this symposium all about? So let me start taking you quickly on a journey. Suppose, imagine, somewhere a new virus emerges. It's highly transmissible, easily spread from human to human, and in our interconnected world, within a couple of days, it has reached every single corner of the world. WHO, within a couple of months, declares it pandemic, crisis. What we then might see is the best of our world. Humans, the species Homo sapiens, come together, the most intelligent scientists, policymakers, and they develop a new health intervention within a couple of months. Let's say a vaccine. But then the question might arise, who has access to this vaccine? How is it delivered? What are equity questions? So you see, not just up front on the R&D, but also as we move along the value chain. And this is really what this symposium is about, the discovery, development of new tools, but how are they brought into the system? So we will try to cover the entire value chain, and I think this is to some extent a bit unusual that EDCTP also funds work upstream, also with a heavy social science context component, but this is what makes this symposium and this consortium, the Saving Consortium, so fascinating. The structure of our symposium is slightly different to the others. We now invite, and my co-chair will invite the 4 speakers, one after the other. They have each 10 minutes sharp, and I'm from Switzerland, so we will take time. If after 9 minutes they have only started with the introduction, I then stand up and they realize, 1 minute left. So after the interventions, no questions, you hold back to them, and at the end of the 4 interventions, we take a couple of technical questions, but then we want to have a panel discussion, of course, with these 4 experts. With that, I hand over to Evelyn, who will briefly introduce one after the other.
Thank you very much. And thank you. Since I've already been introduced, I will introduce the first speaker so that we will have maximum time together. So the first speaker is Professor Margaret Japong of the University of Health and Allied Sciences. She's the director of the Institute of Health Research. So Professor Margaret Japong, you have the...
Thank you very much. Good afternoon, ladies and gentlemen. You are so far away, can you? I want to feel the warmth of everybody if you come forward. Thank you very much, Jörg, for setting the scene for this symposium. As has been said, I'm Margaret Japong, and I'll be giving the context to the Saving Consortium, and I'll share just a bit about what we've done in terms of health system readiness and implementation research to support the access and delivery of new health technologies in Africa. As Jörg said, in 2018, EDCTP issued out a call. And for some of us, it was surprising to see issues around capacity development to facilitate the delivery and uptake of new or improved medical interventions in African health systems. Usually, you would find an EDCTP call on clinical trials or vaccine trials or something. So for us, this was unique. And when I talk about us, some of us had been working on the WHO Implementation Research Toolkit, and we had been building capacity amongst program managers, district health teams. And the same group had also been working with the Access and Delivery Partnership supported through UNDP on looking at building capacity in African health systems for various things. So we saw this call as an opportunity to work together to be able to implement the capacity that had been built, and even an opportunity to build more capacity on institutions that are along the access and delivery value chain. So we put together a consortium known as the Sustainable Access and Delivery of New Vaccines in Ghana Consortium, and it's the SAVING Consortium, without an S, SAVING Consortium. Our objective was to build technical, and technical we are talking about health technology assessment and implementation research capacity in the institutions along the value chain, like I said, which will facilitate the delivery and uptake of any new medical intervention in Ghana using the malaria vaccine as an entry point. So at the time we put the proposal in, the malaria vaccine was being piloted in the 3 countries, Ghana, Malawi, and Kenya. And some of us happened to be doing the qualitative evaluation in Ghana. So why did we decide to put this consortium together to look at these issues? We have less than a decade to the end of the SDGs, and we all know that everybody is putting in a lot of effort to achieving the goals. Several new health technologies, policies have been introduced in our health systems in Africa. Clinical trials have been done, new technology rolled out, and you're supposed to just uptake and roll it out. There are several implementation bottlenecks that come along with this. And in doing our training in implementation research, we realized that some of these issues were very, very real. And a lot of our institutions from the Ministry of Health really sometimes are at a loss as to how to identify and address some of these challenges. So we wanted to be sure that our institutions were better prepared to access these new health technologies and deliver them through the health system with the least amount of problems as possible. So using the, or borrowing from the Access and Delivery Partnership, we had this as a framework that we're using. R&D in the lab, and then coming into the countries, you have to go through regulatory approval, selection and pricing, public procurement, distribution, service delivery, pharmacovigilance, and all of these, through all these processes, there are implementation bottlenecks along the way. And so we phrased our consortium around this. We had UHAS doing the coordination. We have Food and Drugs Authority. We had the Ministry of Health. And then, of course, we needed a European partner. And we got our colleagues from Swiss Tropical and Public Health Institute because we have been working with them for a very long time. Now, doing things in real life is complex. At the time, the new malaria vaccine was introduced in 2019, and then SAVING Consortium started in 2020. Between then and now, we've had the COVID-19 vaccine. Several changes have happened in the Ministry of Health, back and forth. People who approved policies have moved on. Things have changed. This year, we've seen the second malaria vaccine, and then we've had multiple stakeholders with multiple interests at different points along the value chain. And it just tells you that nobody waits for anyone. Once things are produced, they are introduced into the system, and the health sector must be prepared to be able to receive and develop or deliver these. Otherwise, there are issues. So throughout the process, we are currently in our 3rd year of implementation. We've seen health technology assessment in emergency situations like COVID-19 vaccine. What do you do? Health technology in stable conditions, one malaria vaccine and then another one at different times. But the country has to make a decision on what to do. We are looking at issues to do with eligibility criteria, normalization of adverse events following immunization, and issues around critical stakeholders that are needed in this. So we put together a theory of change, and we said that if we build the necessary capacity, technical or implementation research, we are hoping that we would engage the relevant stakeholders. They'll be better informed. There'll be strengthened country ownership and leadership and capacity for decision making. At the end of the day, we are hoping that we'll be able to sustain a system or have a sustainable system where people will be able to access and deploy any kind of new health technology into the health system. We chose to use the implementation research design. We're focusing a lot on stakeholders, the mapping, the engagement, assessing capacity gaps. Where are the challenges? We are currently in phase 2 of implementation of our work. But why did we choose implementation research? It is systematic, demand-driven. We want to be sure that in the Food and Drugs Authority, the Ministry of Health, the Ghana Health Service, they recognize and understand and are able to address the bottlenecks. They are able to identify different options for implementation once they have identified the challenges, and also be able to promote the uptake of research and policy into policy and practice. Of course, the issues that we raise for which work is going to be done are demand-driven. So right from the beginning, we are engaging the stakeholders to find out what is the issue and how can we work at it together. We assessed implementation research need, and you can find from this table that several of our colleagues really are just at the beginning stage of implementation research. Critical to IR is working in multidisciplinary teams, and few of our colleagues have worked in that kind of team before. It's usually siloed. When it came to identifying and prioritizing problems and knowing the importance of stakeholder and community engagement, it's no news. They really had not had that kind of experience. And even issues to do with translating research into policy. And so we decided to focus on capacity building in IR, and we worked with TDR. We've done the MOOC, the Massive Open Online Course, but we did an abridged version. Ministries of Health, Food and Drugs Authority, Ghana Health Service, they are very busy people. Research is not their primary job. So you leave them to do the online course on their own. Many of them drop off. So we did a hybrid where we did the face-to-face together with the online. We camped people a day or two for different modules, and they were able to complete it. And then also we had a whole session on stakeholder analysis and engagement, and people realized the value of doing that. And together, we are just not doing the short-term capacity building, but long-term, so we have masters and PhD students too. We did our stakeholder analysis, which is critical for this work we are doing. We're looking at stakeholders with large influence, those who are most knowledgeable, those with highest interest, those with the most implementation capacity, and those with the capacity to pay, which is the most important, those who have the funds to pay. And you can see from the results that really a lot of people see the Ministry of Health, WHO, the EPI programs as critical to all of this work that needs to be done to ensure that new interventions are accessed into the system. I cannot overemphasize the importance and the value of the stakeholder engagement that we have done. We started when it came to the problem identification, even in developing our proposals, and the dissemination. And it was interesting to see how stakeholders took researchers to task to say, no, you cannot use this approach in our district or in our facility because it will not work. So having our research mind on, they brought us to the reality to say, this does not work. Let's look at it in this way. So we've had to change a lot of things around. In terms of evidence, we are seeing that a lot of people place a lot of value on the guidelines produced by official entities. So the onus is on us to make sure that when we are developing those guidelines, we do it in such a way that it's easy for people to understand and to be able to use. To conclude, we started off by looking at our health system readiness. They didn't pose for this picture. We happened to be in the field and we saw them like that, and we took this picture. Look at how they are preparing to go out to deliver this, the new malaria vaccine. And not enough transport, but everybody sits on it, they are happy and they go along. But basically, we are saying that we want to be sure that our system is prepared so that as new health technologies continue to be introduced into the health system, we are building the necessary capacity to ensure that these are taken up seamlessly and are sustained in our system. Thank you very much.
Thank you very much, Margaret. I think that sets the scene for what we are about to discuss. And our next presenter is Professor Olumide Ogundahusi. And he is the Director of Research and Innovation in the University of medical sciences in Nigeria. So, Professor, you have your...
Thank you very much, and again, good evening, and welcome everybody. I'm going to be talking about African health research systems and early stage R&D innovation in Africa. It's going to be a little bit of a different track from what we would expect when we're talking about implementation research, but it's not quite along that track. But this, again, is the access and delivery value chain, which, like Margaret said earlier on, did form the basis for our thinking with the savings project. And I'll be focusing on the general usual question is that, when we develop an intervention, when it comes to implementing it, there's a disconnect between how to link the two together. But there's even a possibility of a disconnect much earlier on along the products that go into the pipeline, as COVID has shown us to some extent. So I'm going to be focusing on the very early part of that value chain, which is around the research and development, the discovery, preclinical aspects of the development. Clinical trials come later on, and we get the technology, and then it goes through the system. But the early stage R&D will be around the discovery and the preclinical issues around target identification, lib optimization, pharmacology, both dynamics and kinetics, toxicology, and also studies around pre-formulation, things around solubility, active pharmaceutical ingredients, physical chemical properties of the APIs, and also how to scale up from what you do in the lab to working with industry and pharma to end up with a product that will eventually go into clinical trials. Now, there are three major challenges that we see in Africa. Now, we have the research gap. The research gap because there's very limited research around those areas of discovery, target ID, lead optimization, pharmacology, kinetics and dynamics, pre-formulation studies, and like I said earlier on, scaling up. There's a gap in that when it comes to capacity to do that within Africa. There's also a limited exchange of expertise within Africa. As you will see later on, there's been some study and work that has been done several years ago where we find that there's more collaboration between African scientists and scientists in the North, the global North, and Europe, North America, compared to collaboration, among scientists on the continent. So there's a challenge there. But yet there are several centers of excellence, there's several institutions that have very high competence within Africa, but the collaboration between them is quite limited. And then, probably biggest of all, there's a very limited investment in R&D in Africa. So innovation suffers from the chronic underinvestment and poor implementation of even the plans that have been made to invest in innovation. African countries several years ago committed to putting a certain percentage of their GDP into R&D. That hasn't happened, and right now Africa just puts only a tiny 0.1% into R&D and contribute very little in terms of the patents that come out every year. So, several years ago, there was this idea about a network that has a mission to overcome these challenges. And the mission, the two of them, both the mission statement and the vision, actually were designed to address these three challenges which I highlighted a short while ago. Unfortunately, somewhere along the line, we dropped the ball. And that idea really never really caught on. And so with all the plans and all the effort that went to putting together this entity, which would have begun to address some of these issues, it really didn't go anywhere. And so the question now is, with the experience we've had in recent times with COVID happening, where do we go from here? One of the enigmas around COVID was the fact that when you compare the global mortality and impact of COVID, apart from the economic ones, it seems to be quite relatively low in Africa. And nobody really has come to be able to put a finger on exactly what was happening in terms of the scientific basis for why this happened. Perhaps if we had put together a very robust discovery R&D entity on the continent, we might have been able to find some answers. We might be able to have a better understanding of what was going on, and probably that might benefit the global community at large. But we never know. So I think that it will be helpful to take a cue from a utensil that's very, very common in Africa. It's a three-legged pot, and that three-legged pot is very stable. It's used in virtually every traditional society in Africa, from the south to the east to West Africa. And I guess there's hardly anybody who grew up in Africa who isn't familiar with this pot. So I'm looking at a three-pronged approach to discovery, where we focus on early stage R&D and innovation to address the pharmacological issues, the preclinical issues that I talked about a short while ago. And then, of course, when we identify druggable entities from this process, then we talk about the clinical studies. That's relatively been taken care of. EDCTP1 has done a good job and continues to do a good job around that, looking at clinical trials and registration of new technologies. And then going on to see, like Margaret said, just talked about a few minutes ago, when we have those new innovations, new technologies, how do we introduce them into communities so that they are not only being shown to be effective in control settings, but they are also effective in real-life settings where life happens, so to speak. So looking at how to optimize access and delivery of these new health technologies. So there were issues around this in Africa, especially around the early stage discovery. It's still very rudimentary. It's not where we would like to see it to be, but it's something that we also need to begin to focus on, because when we look at certain issues around the African context, or the local context that exists in some of those communities, it might help us and give us ideas as to how to come up with more effective interventions, more effective technologies to address some of these issues. I'm going to end there. That three-legged pot I told you is very stable. It's a very good pot for making jollof. Some of you know what jollof is in this room, but I won't go into the controversy about the best jollof. We'll leave it at that, and we'll talk a little bit more about that when it comes to time to take the questions. Thank you very much.
Thank you very much. There's a running competition between Ghana and Nigeria as to who has the best jollof. But we all know who wins. Okay. So I'll tell you who is the winner at the end, but people here know. So I will introduce now Gary Aslayan, who is from the TDR Special Program for Research and Training in Tropical Diseases in Switzerland. So Gary, over to you.
Great, thank you. And I will not be making jollof rice, although we can make risotto al limone or something like that, which probably is not very different. So I'm here to briefly give you a sense of what TDR has done. Next year, we're going to have our 50th anniversary. Obviously, in the last 50 years, we haven't done all the same things all the time. But most recently, obviously, in our strategy and new strategy going forward, implementation, research, science, and capacity for it is going to have a prominent role, mainly, again, for all those same reasons in terms of bringing new tools, new approaches to capacity building, strengthening, supporting in countries that you already see is happening. So quickly, that's our plan, but I'm obviously not going to do advertisement for our strategy here, but just to say that as a global program, we also engage at global level, and we're basically one or two doors away from organizations like just WHO or UNDP or World Bank that makes it a little bit easier in this. But in terms of capacity building, really the goal here and the programs that we have, and you already heard from Margaret, they're using, for example, the Implementation Research Toolkit. That's something that was globally used, and then massive online course that's been introduced as well. Then looking at gender aspects. So Margaret, maybe this is a course they need to take as well on intersectionality and gender in implementation. And these courses, their beauty or the way they are developed, they are really harnessing the global knowledge and the up-to-date sort of technology to disseminate this capacity, because there's really a lot of gap. And we know that from presentations throughout. But as well, we know it from calls that we have, where you receive call in response to calls for implementation research. You really don't have a lot of variety and good innovative proposals, and that really needs to kind of be changed. But only way to change that is the people should be there to be able to do it. The walls are not going to do that. So another quickly sort of approach here is that we've also inserted that into capacity for clinical research, but as well as the access and delivery partnership that was mentioned earlier here, and also kind of on the system solutions. And that will be more going forward in our strategy, where we'll be responding to global challenges such as climate change or health system resilience. We're not going to address the climate change, but the capacity for implementation research in countries to answer those questions that are going to come up, the bottlenecks and all the issues that are going to come up, to be able to address and quickly have local answers to why that's happening. We have a number of schemes, and really we need to innovate. In fact, if you leave this room, think of what are the capacity building, or ask, or please ask a question or propose, what are the capacity building innovative new approaches we need to apply and use to actually have this critical mass in countries of health professionals. Here we have master's program that is in 8, 9 universities in Africa, but obviously it's globally as well. And all of these universities are training MPH students. They are not training PhDs. They are training MPH students with implementation research focus. So our hope is that they will be working in the system and have appreciation for evidence that they have, or create that evidence, or to ask questions. And that's the most important issue here. And ask questions why things are happening, and look for research or look for solutions through research. So one of the other ways we do that is what is called sorted. So that's another example where for a year, public health professional, in this case, let's say Saving is looking at vaccines. This could be snake bite, this could be malaria, this could be TB, this could be a whole bunch of other NTDs or system issues in countries, where the person who is working in the public health department has a question and says, I have this problem and I have piles of data. I'm going to go through this with you for 4 modules, and by the end of it, I'm going to have an answer. And I don't need to convince anybody else, because that anybody else is me. Because I'm going to find the answer to my question, and then I'm going to go to my boss and say, remember I told you we have this problem, now I know why. And I used research, and I used a sorted program to facilitate that process, but they are responsible for answering that question. We have recently also, and I'm sure Cecilia will look at this access and delivery partnership in more detail. We've looked at the current sort of trends in digital health and their use in public health. But most importantly as well, these are just examples of what been applied or what was been used. But most importantly, some of this is also used to actually conduct the implementation research projects and have them sort of as tools. And that's another thing. We need to do more of this. We just need to find out how. There's AI. How would AI help us? AI help us in training? Will AI help us in conducting research? Will AI help us in any other way? So let's think about those things as we come to discussion. Funders, both in countries and global funders, still have a hard time distinguishing capacity building as an important area. And this really is not a criticism, but it's mainly an observation, because it's harder to wait for 10 years and see someone's career resulting in applying their skills, etc. So they've actually, some of them ask, and we have a program that supports a secretariat of funders called Essence. And they wanted to come up with a guiding document. So if you know any funders you're working with who tell you that they cannot fund capacity building, or they are looking at ways to fund capacity building, look up this document, because it's a quick guide for funders how to fund with about 4 or 5 guiding principles. Obviously, I cannot go into detail, but just to say these changes have to also happen at different level. And again, as a global program, we're best suited to do that, but some others, obviously, amongst you can do this in a different way from the where you are. I think that was it.
So, thank you very much, Gary. So now we've seen different opportunities for training, particularly including in implementation research. So last but not the least, we have our last presenter, who is Cecilia O from the Access and Delivery Partnership in Thailand. Cecilia, you have the floor.
Thank you so much. Good evening, everyone. So nice that you're all still in the room at 5 p.m. As Evelyn says, I'm with the Access and Delivery Partnership, and I think you've heard the Access and Delivery Partnership mentioned a couple of times, but I don't think we've really introduced it. So I think we should, let me just do that. The ADP, as we like to call it, is a multi-agency global health project, which is comprised of UNDP, TDR, WHO, and PATH. So, you know, none of these names should be unfamiliar to you. And I've had the pleasure and the privilege of working with the ADP for the last 10 years, which I think is also a bit of a record in itself. But maybe just let's start with, you know, what I was hoping to do in terms of setting the context for why the Access and Delivery Partnership and the value chain approach is important. Not just in terms of understanding health system strengthening and capacity development, but it really is to try and figure out what is it that we mean when we say we need an end-to-end approach in terms of looking at innovation, access, and delivery. How do we get the innovation to the people who need them? And I think, as Jörg mentioned, you know, we know all of this, but I think the pandemic really underscored the importance of this, which is that we saw, you know, having the global R&D community come together, resulting in the multiple COVID-19 vaccines. But we also saw that when it came to actually delivering these vaccines on the ground, there were a number of challenges and bottlenecks. So we think that obviously there has to be a concurrent need, you know, to support all of this global coordination in science and R&D with, you know, sort of national health systems that are robust and resilient. And this means that we need to build that capacity. And when we say build capacity in health systems, it's also something that we understand that that capacity has to stretch across, you know, multiple national health functions. So I guess the key point is that, you know, we know that even when new health technologies are available, and we're seeing more of these now because we focus on TB, malaria, and NTDs, we're talking about the RTSS vaccine, the R21. We're also looking to see now that, you know, there are new diagnostics as well as new treatments for some of the NTDs. All this is exciting, but I think we're also clear that the success in terms of introducing these new health technologies depend on we hopefully coordinated well-functioning health systems and national institutions that are able to provide that end-to-end approach that links up, sort of everything from access to procurement and delivery. So, as I promised, the ADP, or the Access and Delivery Partnership, it's a mouthful, but I think we started off 10 years ago trying to figure out what is it that is needed in terms of actual capacity strengthening within the health system that would work. And I think we got to the point, having talked to various people and talked to all of our partners, that it is integrated and multi-sectoral support for health system strengthening. Everything from the policy and legal frameworks that need to be put in place, implementation research that you just heard about, the regulatory system, as well as the procurement and supply chain management issues, and then ultimately to the actual service and health technology delivery, and then the sort of the patient monitoring system, or the pharmacovigilance systems. And I think what we saw too was that as we started doing the work with ADP partners, the COVID-19 showed us that some of the investments we made in health system strengthening did pay off, that put some countries in a much better position to be able to sort of deliver the urgent responses that were needed. Just very quickly, we work in 9 countries now, but we also want to look at how we can share what we've learned with other countries through South-South cooperation. You've seen this value chain. If there's anything that you want to do going out of this room later before your cocktails in the evening, is to maybe ask, why are we showing this diagram so often? And I think you'll also see that the diagram has evolved and changed, and this is, I think, possibly the latest evolution of the diagram, which is really just to say that when we talk about health system strengthening and the ability to deliver new health technologies, this to us means that ultimately this contributes to universal health coverage. But also, with COVID-19, we also see that this is really part of pandemic preparedness and response. So it's all interlinked. UHC and pandemic preparedness, or pandemic prevention, preparedness and response go hand in hand. Basically, health systems need to be prepared to deliver essential health services for UHC, but also be able to deliver those and be able to deliver urgent responses all at the same time. If you can't do that, then obviously something is missing. So there's a lot of work to do. We then decided that in learning through the years, there were probably 4 priority areas that we thought we should be focusing on going forward. I think Gary talked about, the digital tools and solutions. I think what we're looking at is sort of a digital transformation of the health sector. Very big, ambitious words. But essentially, it is trying to have more of an ecosystem approach, not just using digital for the sake of digital, but really trying to understand why we use a digital tool or a solution, because, the idea is to increase the efficiency and the effectiveness of the health system. The other thing, obviously, is about the regulatory systems and strengthening harmonization. I'm sure we've all read many journal articles about why is it that there are bottlenecks in terms of, health technology delivery. The regulatory systems or the approval systems take too long, so on and so forth. We can do a lot there by looking at how we strengthen and harmonize regulatory systems. But I think at the heart of it all is, how do we then safeguard and scale up our responses to TB, malaria, and NTD? Because we know with COVID-19, we actually saw a degradation of the responses for TB, malaria, and NTDs. And if we are really serious in talking about TB, malaria, and NTDs as basically the indicators of poverty and inequality, then we need to be thinking about how do we enhance what we do in our responses. And then finally, yet another term and a mouthful that is unfamiliar to people, but uniting efforts for innovation, access, and delivery. And this is really a global platform that we set up in 2019 to bring together what we saw as different components for health systems. It's the innovation people who fund innovation, the innovators themselves, with the access and delivery actors who are working on the ground, at the regional level, on the ground, as well as the global level. Because that's how you have an end-to-end approach in terms of looking at when you do R&D, you need to embed access considerations in your R&D process. It's not something that you do as you look at phase 2 trials. It's something that you do as you think about it right from the beginning. Easier said than done, but I think that's something that we are trying, hopefully, to get to. So if we had all of this, then I think the outcomes that we would hope for is that at the country level, there are these multi-sectoral platforms, as we've seen in Ghana with the Saving Consortium, able to plan together for the rollout of new health technologies, but that these are the sorts of models that we can then adapt and apply in other countries, but in other contexts as well. So that's our hope and ambition. We've talked about the malaria vaccines, and I think what is also, sort of instructive for us is that all of this is great. There is such, optimism and hope for the RTSS as well as the new R21. But it's 3 countries and a pilot program. What we're hoping to see then is through the work of our partners, how do we scale up what we've learnt, And I think the proposal is, and it's, you've probably heard from the earlier sessions yesterday, to work with the countries that are actually practicing or using seasonal malaria, oh my God, chemoprevention, SMC. Never had so much pressure before when the chair stands up. But I think the idea is really to have a look at that value chain approach, but then leverage existing systems that are already in place for chemoprevention to, sort of look at how you schedule vaccination for RTSS or R21, and then, obviously improve the outreach to as many children as we can get. And then the last slide is really to look at the new health technology that's become available. We know schisto is a persistent problem, but we also know that pediatric praziquantel formulation is imminently available. It's gone to the EMA for hopefully a positive scientific opinion next year. And the Access and Delivery Partnership is wanting to look at how we adopt this value chain approach to the introduction and rollout of pediatric praziquantel. So here's another value chain. Unfortunately, we couldn't figure out how to make it, sort of circular. But the idea is really looking at how we accelerate regulatory approval through the WHO's collaborative registration procedure. How do we ensure that there is safety monitoring, including pharmacovigilance through our work with both WHO and TDR. How we look at supporting the quantification exercises just to know how much we're going to need in terms of pediatric praziquantel, but also how do we make sure that there is security of supply in terms of production. And we know that there might be issues with that as well. So then we want to conduct that supply chain analysis to ensure that we don't have that problem. And once we, as we're doing that, we want to then see if we can then address some of the other implementation challenges through the use of digital solutions. Everything from pharmacovigilance right down to, sort of inventory and logistics management. And then, I think that was the part where we couldn't figure out how to put it all together, which is that we probably need to convene all of the stakeholders who are involved in this, who are interested in this. Everyone from, the innovators who came up with the new formulation to all of us, as well as the countries who are interested in the potential imminent rollout and introduction of pediatric praziquantel. And I think, Mr. Chair, I'm done. Thank you.
Good, wonderful. You have seen this trick of standing up. This was excellent. I had to stand up once or twice, but everybody really stick perfectly to time. We would now like to ask the 4 speakers to take a seat. And in the next 10 minutes or so, we would just like to ask you if you have specific technical questions to one or the other speaker. And that gives us then an additional half an hour to have more of a kind of a panel discussion. But first, now, whether you have some specific technical questions, just say who you are and to whom the question is addressed.
Thank you. My name is Jutta Reinhardrup from Merck. I don't know whether it's a technical question. It's a question to Cecilia for the last presentation. I'm part of this pediatric praziquantel consortium. We expect this EMA opinion in December, in 4 weeks' time. We have tablets ready to go, but we are an R&D consortium. We think about access since 10 years, but we are not the experts on that. So I see there are many things happening and coming together. Still, we are very much concerned about this whole mechanism after we have done R&D. So for us, it's very complex to understand who is going to procure the product. We have a manufacturer in Kenya. We have everything that according to the book, but for NTDs, it's very difficult. Thank you.
Take it now? Okay, great. Can you hear me? Thank you. Excellent. I knew I was going to meet somebody important at this conference, so wonderful. Look, I think clearly, you know, we need to be talking together. As you say, you're R&D, and we are looking at access and delivery. And so in a short answer to your question, I think the idea is that we are, as ADP and the GHIT fund, as you know, that's you know, sort of invested in the product development. We're going to try to bring together all of the key stakeholders in a meeting. I think there is a need to try and figure out how we develop a roadmap that brings together, you know, all of the different stakeholders, figure out the responsibilities. The WHO NTD department is looking at quantification exercises. We're looking at, you know, sort of bringing together the different partners in terms of the different roles. Whilst we wait for the AMA scientific opinion, I think we're trying to make sure that our partners in WHO are ready to look at WHO pre-qualification as well as the CRP processes. So, you know, I think it really is as simple or as difficult as getting all of the right people together at the right time, you know, and starting to speak to each other across the table. But I think the outcome that we're hoping for is that perhaps by early next year, Q1, is that we will have this meeting and that we will be able then to have some idea of fleshing out what this roadmap would look like with the interested countries. We know that we're talking about at least 5 countries, but I think this is an opportunity to see if we can open that up to see if we can invite other countries that are interested to join us. I hope that's an answer.
Other questions, please.
Hi all, it's good to see you. My name is Spring Gombe. I am with Market Access Africa. My question is for you, Margaret. So we have RTSS, and R21 within 1.5 years of each other, which is great for malaria and great for all the children who may benefit, but a difficult thing for finance ministries. In your slide, you talked about the importance of involving the people who would pay. What do you need to help them make the decisions about what goes into a portfolio that they invest in for malaria interventions for children? Or how do they make the decision about whether RTSS or R21? Because those are the practical decisions that have to be made on the ground.
Thank you very much for that. And I have asked the Ministry of Health that question before. We are having 2 at the same time. Which one are we going to use in the health system? Sometimes I get the answer that 2 of them are going to be available, and whichever they are able to procure that goes through the system, then they would use. I said sometimes you have the challenges with, if it is the mother and the 2 are available, you can't ask which one do you want. I mean, they are depending on the health system to be able to do this. But I get it all boils down to the issue of engagement and sitting at the table and discussing to look at what does it take. The Ministry of Health may say health technology assessment, new vaccine, which one should we take? What are the cost benefits of using each of them. So I cannot give you a direct answer. Each country would have to sit and look at the evidence and take a decision on the way forward. And then once the decision has been taken, the information needs to be communicated properly to those who are using it. Otherwise, it creates more trouble than good. Thank you.
Thank you. I'm Lenia Swender from Medicines for Africa. I'm also on the advisory committee for EDCTP 3. My question goes to the prof who talked about, you showed a figure on discovery, clinical studies, and implementation research. And I wanted to know if you know of any work that is currently ongoing, doing a little bit like what US Pharmacopoeia does, you know, on formulation, standard setting, and that kind of thing. Is there anything that is currently ongoing on the continent, projects like that maybe you could elaborate on, you know, whether there's work that is tackling that side of things on your figure? Thank you. And I have a suggestion on how to set the jollof walls. I've been to Accra many times, and the jollof rice there is very good. And I think you need to invite me to Nigeria, and I will settle it once and for all.
Okay.
Can I come too?
What? No, let's do the jollof for now. Let's talk about science. Well, the simple answer to your question is I don't have that information, but like I said, there are several pockets of things going on in different countries in Africa. The unfortunate thing is that there's no coordination. There isn't a very good network of bringing them together and having a repository of what's going on where. I know Nepal was trying to do something some years ago, but I don't know exactly where that effort is right now. But that's something that we need to look into.
Hello, good evening. So I'm Fabienne Benoit, DNDi, Regulatory Science. I have a question for you, Cecilia. So it's to link with what you discuss. I must say I'm very surprised that we don't link R&D on access. How I see is that there is no reason to go for research if you don't have access plan. Regulatory is not anymore regulatory at the end of a story. So a roadmap, regulatory is from the beginning until the end. Registration is at the end, not regulatory. So I think what I hear, I have example of, yes, EMEA, positive opinion, but this is the end of the story. And you don't need a WHO if it's not a vaccine later on. WHO is part of the EMEA opinion. Then you don't need the collaborative. The country are already in the picture. So I think, especially in Africa, the regulatory framework is moving very fast. Countries are involved now from the beginning, and they have a way to even register a drug by themselves, with the EU or not. And also a very good example of where we link completely regulatory research and development and access is what WHO has just put in place, and I'm really supporting of that. They had a conference 2 weeks ago. Now, WHO is pre-qualification is completely aligned with policymaker. They have put in place a lot of process, CSA, coordination, scientific advice. So we don't talk anymore about registration and then access. We talk about all together. And the policy, WHO policy, is completely aligned with regulatory and R&D. So I'm very positive. It's something I was waiting for years. And I think we are really now moving very well. And Africa is a very good example of the world. A lot is happening. African Medicine Agency, etc. So I can give a lot of examples, but I don't want to make a show by myself. So thanks. I think it's a very good sign.
Very good. So these were the 10 minutes of, let's say, technical questions, but I think we already moved into the panel discussion. This also is for me a wonderful opportunity to say goodbye, because I have to catch a train. But my co-chair, Evelyn, will now masterfully chair the remaining half hours. And don't forget, at the very end, All of them give a 30-second statement, and I would suggest after 25 seconds you stand up and then they stick to time.
Thank you. Yeah. Okay. Thank you very much. I'm not as tall as him, so I prefer to stand here so I can see you and you can see me. So do we have any other questions? Yes, please. At the back.
very end.
Far right, yes.
Thank you.
Thank you. My name is Akin Wale Ojomo. Originally from Nigeria, but I live in France now. So my question is not a technical question. It's not a technical one. So it's going to be very, very simple, right? I run Diaspora Innovation Institute, and of course, the diaspora, as we all know, has so much impact in remittances, which is the big word, you know. But I'm not talking about the big numbers now. I'm going to talk about the human capacity, which I think this forum should be able to tap into. So you have folks who have left Africa and been in the United States.
Your mic is on.
Okay. Can you hear me? Okay. Now they are interested in giving back, right? So in giving back, number one, we volunteer. We do medical missions. We do tons of things. However, though, I think there's no sustainability in some of this, and we've really figured it out. We believe that forum like this should be able to really give that backward integration for them to be able to say, it could be a 3-month exchange program. It could be an internship in some of these institutions that have been developed. So 2 things are going to happen. They got the brain already. They got the experiences already. They got the cultural competencies that will make such projects sustainable. It's a free advice. Thank you so much.
Okay, so thank you for the free advice. Any other question from the audience? Any other question? I have a question for you, the panel. We've talked about different vaccines coming through the pipeline. We've experienced the RTSS vaccine, and then now R21 coming through the pipeline. And we are not just talking about vaccines here, we are talking about health technologies. So different things could come in. Cecilia referred to the Med Safety app in Ghana, which has come through the pipeline. What is the role, Professor Olumide, of engaging the implementation research at the very beginning of your 3-legged pot? You talked about the 3-legged pot starting from right from the discovery stage. What is the role of employees? Does it have any role?
Yeah, absolutely. I think it does. I think it does in the sense that you know, there are stakeholders involved. You need to know what the need, and that should also, to some extent, drive your innovation, so that you are innovating for a product that would fit that context. Sometimes you have a really good tool. You've put in a lot of effort into the discovery and all the background research to develop the product. But then you have the product, it doesn't work in that context. And I think that's the whole essence of IR, really, to be able to understand the contexts so that can enhance the effectiveness of your intervention. So if you have an app, for example, which works very well, I mean, you can go put it through all the tests and it works very well, but then the people don't use it, then, you know, it's not really fit for purpose. So yes, I think there's a role even for early R&D innovation to drive what you're going to be spending your time to probe, either in the lab or wherever.
Gary, you want to add
just,
on? Yes.
But it will not happen in the vacuum by walls or by chairs. It will have to happen by qualified people who should be able to do that research. So it's very obvious, but I think we need to repeat this many times, how best to have this capacity in countries that local, not parachuted from somewhere, research done by local public health, research public health partnerships to answer those questions that will come up inevitably in every context. And that research should be of just as good quality as of any, because you cannot just say, we're going to do some research to find out, and maybe we have a right answer, and maybe we don't have a right answer. So all of that requires people qualified, trained, retrained somehow, adding some skills that then they can use and actually do that research. Because if you don't have the people, it will not happen. You will be with your question, with your information, but you won't know, nothing will happen.
Okay, so thank you very much. Yes, Margaret, you wanted to add on.
From the Saving Consortium experience, just like Gary said, it's important to have the partnership, to have the program people and the researchers together. When we started off, we were trying to build the IR capacity in our the colleagues in the Ministries of Health, Food and Drugs Authority. But we quickly realized that because it is not their primary job, sometimes it is difficult for them to follow through. So we had to include what we call embedded scientists. So we had scientists from the academic institutions partnering with them so that as the program people brought in the context and the reality on the ground, they also brought together their research skills. And like Gary said, do it in a systematic and a proper way to get the real results that will drive what has to be done.
Okay, Professor.
Yeah, thank you. I'm John Japon from Ghana. This week I've been in a meeting where we were discussing some scientific priorities for NTDs. And somebody spoke eloquently about the fact that to take the fight against schistosomiasis to the very end, we need to address children under 5 and children out of school. And one of the key problems the person identified was lack of pediatric praziquantel. And then here we hear about R&D telling us that it's on the way, it's coming. At what stage do we decide which product gets into this pipeline to see how we can work with it? I mean, there are so many products that are coming. When do we decide? And who decides which product to incorporate into the system?
So it means that the product is on the train and it's moving, and then people are thinking about, we need this product, and all of it is not. So can you respond to it? Yes, Cecilia, I think you should respond to this.
I think when we started with the Access and Delivery Partnership, we had a problem because we said we wanted to focus on TB, malaria, and NTDs. 10 years ago, I think the pipeline was pretty empty. It's a really positive development that we're now seeing so many products. But in reality, I think we're talking about RTSS R21, pediatric praziquantel, a number of diagnostics. So it's not a huge pipeline. But I do understand the issue about thinking about prioritization, thinking about, sort of informing the decision making, and obviously it's about financing. So I think there are a number of tools that are already being used, maybe not in TB, malaria, and neglected diseases, but the health technology assessment is a tool that will allow for, some, sort of basis for evidence-based, or it's like, sort of decision making. And it's also, sort of thinking about, what is it that the health system should pay for, can pay for, is able to pay for. I think what is really also worrying is that the idea of donations for NTD treatments are kind of like passé. I think that is something that is, sort of worrying. It's a worrying trend, but I think this is the world that we live in now, that we're starting to think about procurement of treatments for NTDs. And so I think it becomes even more important that we think about, what is the, the investment and the benefits out of, sort of implementing a supply chain that will get the treatments to the people who need them. But also, I think that's what Fabienne was saying, that when we think about R&D, we need to be thinking about the needs right from the beginning. It's not about saying, I'd like to do this because it's kind of fun. I'd like to do this because we know that there is a disease burden. It's a big challenge, and we need to be able to figure out the better solution than what we have now. And then integrating into that, what are realistic expectations of the access challenges that is going to be faced at the ground level. And the access challenges are unfortunately going to be different in different contexts. So, it really is having a much better picture of what the needs are at the ground level, but what are the challenges and the gaps that, we still have in terms of the health systems across the countries. So it's not a perfect answer. I don't have the perfect answer, but I think we need to be thinking about consolidating these, the tools that we have. But also, I think, the value chain that you've been looking at probably needs to change too, because we now know more than we did before. So that's something that we probably all have to work on, because it's not the job of, one single entity. And I'm afraid that's an inadequate answer. So I'm going to ask the rest of the panel to deal with it.
Okay.
So I just want to make a comment. And Professor Japan asked the question, who decides? Well, donors decide. International health agencies decide. But I really think the countries should decide. The countries should see what works best for them and what they can afford and make that decision. Of course, you know that in many of the LMICs, low and middle income countries, there were challenges with financing, but ultimately, really, my opinion is that the countries should be the ones who ultimately make the decision and should have the capacity to do so.
We are dealing with a current situation in the Saving Consortium where Cecilia mentioned health technology assessment. And one of the questions that the Ministry of Health is trying to answer is why, like I said in my presentation, why the ministry did not take the advice when it came to deciding which of the COVID-19 vaccines to procure into the country. When we engaged with the stakeholders, one of the first things they said was that the process is too long. By the time they finished going through the process, the minister had taken a decision. So there are several contextual issues that come to bear. As a minister of health, there's pressure on you to deliver something. You need to choose a vaccine, and you have to think quickly, So sometimes, yes, it is not as nicely laid out as we've done it on paper. Things happen, and some of those decisions need to be made on the spur of the moment. But we are still trying to address the issue with some of the research that we are doing. We are trying to look at what possible interventions to put in place for the issue that we identified. We are still working on it. Hopefully you hear about it one of these days.
So that then tells us that whatever is going on in the value chain, it's not just a straight train ride to the end. As we go along, we are going to face bottlenecks from time to time, and we need to regroup, look at it, address the bottleneck, and allow the train to move through. So we have a question from here.
Thanks. Actually, it follows up on what, Margaret, you've just said. My question was triggered by what you, Olumide, had referred to, and Gary a little bit also. What does anticipatory good implementation research look like in two contexts? First, an emergency. And second, for the African continent, with adolescent populations, because that's the majority of the population that we're dealing with, right? And if you think about digital health technologies, how do you do research that will answer their evolving needs?
That's for malaria only.
Well, let me just share some of my thoughts around this. Ultimately, for me, what I should do is to find out what works best in a context. So, and it will vary from country to country. It's never one size fits all. So I think that the critical thing is to have the capacity or human resource in that country or context to look at what is our situation, what are the issues that we are looking at in terms of barriers or facilitators, and also how can we put in place strategies or efforts to mitigate these challenges and overcome these barriers. So ultimately, IR really is not one size fits all. Requires a lot of local context and local capacity. People who are familiar, with the terrain, and that's where the capacity building comes in. And the people who are there, who will be doing this, should know the science and know how to go about the research. I don't know if that's helpful, but
yeah, and it's not the goal. The IR is not the goal. IR, different methods are the tools to answer the question, right? So that's also the other thing to put it on the table, that the goal is not to do the IR for the sake of doing it. It's IR offers different methods, approaches, how to get the data, information to answer a question at hand. But the actual question matters, and what method to use, be that if your audience or your study population is using that kind of technology, then maybe that's how you're going to answer a question at hand. If it's another population or another question, then that's another tool. Or if it's another social kind of issue that requires qualitative research and in-depth interviews or panels of people to come up with a solution, because they are not very technological. They have to do with values or the perceptions of people, of what they think certain health technologies are. That's a very different research than you'll have to conduct to identify where are these myths coming from and how can you deal with busting those myths with that information, but cannot be done anecdotally. That's the most important thing. It has to kind of be done in a science research process, qualitative, quantitative, or a combination, and answer the question and say, here is what is really the issue, and we have this information. And to tackle it, here is what we recommend we do, right? So, and it will be different in different countries, different contexts, everywhere. But then you have to have people to do that research, and not in 5 years and published in another 5 years, and that paper will be out there. It will be done in a year to answer the minister's question, because he has to sign that memorandum to sign off on the money.
Okay, so that tells us then that for what we are discussing, the nature of the bottleneck is important. It matters. The context matters. The stakeholders who are in that context matters, and it's not a one-size-fits-all. It varies and must be adapted to that context. But you have a question.
Thank you. I wanted to follow up on the question that Prof. Japong asked on who decides, and then the issue of capacity. You answered that often it's the donors who are deciding, but actually the countries should be making that decision. Now, my question goes to Prof. Margaret. How should institutions such as yours be working or maybe supporting officials who find themselves having to participate in conversations at a global level, sometimes where such decisions are made? I'm thinking here of an instance a couple of years ago, 2019, when I co-chaired global negotiations on the transparency of markets for vaccines and medicines and other medical products in the World Health Organization during the assembly. And the challenge that I particularly faced as a co-chair from the Africa region was that a lot of the delegates that were participating in that conversation were regulators, medicines regulators, and they hadn't, were a lot of different issues, policy issues that perhaps they were not very conversant on, so that they could participate fully in the conversation and bring all of the knowledge that they needed to bring to bear on that conversation. So my question is, how can academic institutions such as yours perhaps contribute to preparing, especially when there are critical questions that are being discussed that impact access in our countries, where we send representatives who have to go and then speak on behalf of entire nations? Thank you.
Thank you very much. That's a difficult question. When an invitation goes to a country and they are told, there's this meeting here, select somebody to go, it's up to the person who receives the letter to decide who should go for that meeting. And sometimes it's beyond the remit of certain people. So you expect a particular category of person to go to a certain kind of meeting, but it's not that kind of person who is sent. And so the person cannot articulate or talk on the issues that are there. But talking about implementation research, I mean, we've been talking about it for quite a long time, but it's currently hitting the fact that it's important that it's not just done by academics, but it's important that it brings the people who are on the ground together with the academics to discuss the real life issues. With the rollout of the new RTSS vaccine, because of the approach of IR, those of us doing the research were constantly in the meetings where discussions and decisions were being made. And sometimes even before you've submitted a report or you have a policy brief, the program manager is sitting there and has taken some of the ideas that you've put forward in a presentation and is using it. So in Ghana, for instance, right now, one of the concerns the health workers and the community had was, why is it that the child has to wait so long after the 3rd dose to get the 4th dose? It was, the women were not going, the health workers thought it was too much. Today, the EPI program manager and his team have decided we'll do it at 18 months and not 24 months, and the uptake has gone up. So with the process of IR, you are constantly engaging. You don't start and wait till the end before you share the results. At every important meeting, you are there to share what you are finding, and you find out that the results are taken up. They don't wait for the publication. They find something that is relevant, they pick it up, and they use it, and the country goes. So it's a process, and we need to pay attention to that and ensure that it happens so that everybody feels that they are important. It's not just calling just a few people. Everybody has a stake in whatever has to happen. And that's why we've spent time doing the analysis of who the stakeholders are with each of the partner institutions along the value chain, so that they don't just think off the top of their heads and say, I want to work with A or B, but they are looking at the core problem and trying to work with who can help them best solve it.
Okay, so that brings us to a point where I would like to ask you in 1 minute, one key take-home message that you want to give to the audience. One message.
I think I just gave my message.
No, okay, so
the stakeholders, for me, that is critical. Engaging the relevant people on the issues so that everybody has a stake in what is going on.
Okay.
Well, somebody asked the question that actually spoke to my take-home message, and that's that early stage R&D also needs to be looked at and given a place of prominence in the African context also, because that can drive the discovery and innovation of relevant tools on the continent.
I mean, just to add also that the R&D, what also happened here is that the R&D cannot not think of the access by design at the time when that R&D is done. So actual implementation and the issues of implementation should also be engraved in that from the beginning rather than thinking of it after. and have that a bit more planned. I think that's another thing that we don't do as well. We think of it once we have the thing rather than in advance of it being out there.
Nobody took 1 minute, so I'm going to take maybe 30 seconds.
30 seconds, yeah.
In UNDP, we struggle with this, but I think we've come up with 3 words. It's sort of agile, anticipatory, and adaptive governance. But, in the House, in UNDP, we think of this as just a governance issue. But for us, I think the governance issue is very broad, and it should also cover the health sector as well. And I think that's what health systems need to be doing, to be, sort of agile, anticipatory, and adaptive, because that's clearly what's going to happen, when the next pandemic hits us. Because there's a 47% chance, apparently, that we're going to see a pandemic of the scale of COVID-19 within our lifetimes. So the AAA becomes extremely important that we're able to do this. But what are the ingredients of the AAA? And I think that's, what we've just been talking about, that countries all have to have a say. But to be able to have that say, they need to be, capacitated. They need to have their own capacities to make their own decisions, and that is a process that's ongoing. The second thing would be that, we need to be thinking about, the coalescing of needs, R&D, and access all together, because as much as we say that we want it, it's not happening because they're all being done by different entities. And so there has to be that need starting now. How do we make sure that there is that multi-sectoral and consolidated approach? I think that's the only way that we're able to get to the AAA and to deal with both achieving universal health coverage and dealing with the next pandemic that comes our way. And on that really happy note, I'm going to stop. Thank you.
At this point, I just want to pick and pull together one key thing that we have discussed here. We have learned that in delivering a new intervention, we may have the most efficacious intervention, but that does not mean it will arrive in the same form as we sent it off on the train. There are or may be some bottlenecks along the access and delivery chain that may arise and that may hinder the movement of that intervention to the target beneficiaries. And we have learned that an end-to-end approach is very important, looking at it right from the beginning till when it gets to the last mile, from innovation right to where it gets to the beneficiary is very important. And monitoring this process as it carries on and addressing the bottlenecks with the involvement of the stakeholders that are involved is very critical. So I want to thank you on behalf of my co-chair and myself and the presenters. I want to thank you for staying through with us till this time, and we hope to meet again when we have more results. Thank you very much.
So thank you, yeah.
Thank you. You know what my last one was? My last comment.
I was going to talk about.
Said, no, let us do this.